This is a chest seal. Specifically, this is a vented chest seal. This one in particular is the Halo vented chest seal, one of the CoTCCC recommended options. It cost me about $15. It is a square of specialized adhesive film with a one-way valve in the middle. And I have watched civilian students apply this device correctly to the correct wound at the correct moment in a way that still killed the training mannequin. The problem was not the device. The problem was a detail the package does not tell you. We are going to fix that today. I am Dr. Marco Torres, and this is Talking TACMED, Episode 6. The chest seals live at the art in March, respiration. They exist to solve one specific problem, a penetrating chest wound that has created an open pathway between the outside air and the pleural space, which is the cavity that surrounds the lung. Now, without intervention, that pathway can do one of two catastrophic things, and the design of the seal has to account for both. This episode is for anyone who has bought a chest seal, is thinking about buying one, or has a chest seal in their IFAK, but has never opened the package. By the end of this episode, you will understand exactly what a tension pneumothorax is, why a vented chest seals were adopted as the CoTCCC recommended standard, and what the one mistake is that renders either kind useless. This is a gear autopsy. I'm going to take the device apart physiologically and show you what it is actually doing. Now, let me walk you through what is happening inside the chest when a penetrating wound occurs. Normal respiratory physiology. The pleural space is a thin sealed cavity between the lung and the chest wall. It normally contains a small amount of fluid and exists at a slightly negative pressure relative to the atmosphere. That negative pressure is what allows the lung to stay inflated. When you breathe in, your diaphragm drops, your chest wall expands, the negative pressure deepens, and air rushes into the lung through the airway. This is a normal system. When you have an open pneumothorax, this is caused by a penetrating wound, a knife, a bullet fragment, a sharp object, it doesn't matter. When any of these things punches through the chest wall, it creates a hole, and that hole goes into the pleural space. Now, with every breath, air enters the pleural space through the wound instead of, or in addition to, entering the lung through the airway. The lung on that side can collapse. The patient can breathe, but ventilation on the injured side is compromised. This is called a sucking chest wound because you can often hear air moving through the wound with respirations. When you have a tension pneumothorax, this is the escalation. If the wound acts as a one-way valve, air enters on inhalation but cannot escape on exhalation. Pressure builds inside this pleural space. The lung on that side collapses completely. The mediastinum, right, which is like the central structures of the chest, that includes the heart and the great vessels, it's going to shift towards the uninjured side. The vena cava kinks. Venous return to the heart drops. Cardiac output collapses, and without intervention, death can follow in, let's say, 10 to 20 minutes. Now, the chest seal is designed to sit at the intersection of those two scenarios. It has to close the hole, right? Converting an open pneumothorax into something the lung can work around without creating a one-way valve that accelerates it into a tension pneumothorax. That single design requirement is why the vented chest seal exists and why the unvented one standard was downgraded in the most recent CoTCCC guidelines. For years, the field standard was an unvented occlusive dressing, a flat, sticky square with no valve. You slapped it over the wound, it sealed the hole, and you moved on. The problem was that in a subset of patients, it converted an open pneumothorax into a tension pneumothorax. The seal trapped air on the inside, pressure built, patients died. CoTCCC reviewed the data, ran animal studies, and in 2014, an update issued a formal recommendation change. The vented chest seal, a seal with a one-way valve that allows air to escape the pleural space but not enter, became the CoTCCC recommended standard. The unvented seal remains acceptable if a vented seal is not available, with the added requirement that the responder monitor for signs of tension pneumothorax and be prepared to burp the seal by lifting a corner to release trapped pressure. That is the doctrine. Vented is first choice. Unvented is second choice with active monitoring. Now, the detail the packaging doesn't tell you, there are two. Detail one, skin preparation. Chest seals adhere using medical grade adhesive. That adhesive doesn't work well on skin that is wet with blood, sweat, or water. So before you apply the seal, you wipe the area around the wound dry with gauze or cloth. You don't need to scrub it, you need to dry it. A seal applied to wet skin can peel off within a minute, usually, of course, in the worst possible moment. This single step is the most common civilian failure with the device. Detail two, every penetrating wound is two wounds for the most part, right? Think about it. A knife goes in, a bullet comes in. Most of the time, there's an entry wound and a wound path. And for gunshots and many stab wounds, there can be an exit wound as well. If you seal the entry and miss the exit, you have created exactly the one-way valve you were trying to prevent, except that now the trapped air has no escape route at all. The doctrine is, after you apply a seal to the obvious wound, you'll roll the patient and you look for an exit. If you find one, it gets a seal too. This is why CoTCCC recommend that chest seals back come in paired. 2 seals per wound, not 1. So, of course, now we should discuss a specific scene, right? You have a parking lot outside a bar. It's late. There has been a fight. One person is on the ground on their back. You can see a puncture wound on the left side of the chest, just below the collarbone, about the size of a quarter. The patient is conscious, breathing fast, shallow, and you can hear a distinct sucking sound from the wound on each inhalation. Now, there's no obvious arterial bleed. There's no head injury visible. This is a penetrating chest wound. It's isolated. Now, your move. March, the March assessment. M, no massive hemorrhage. So we don't have a tourniquet and a minimal bleed here. A, the airway is patent. Why? Because the patient is talking. R, here we are. Open pneumothorax. So now you have to intervene, right? In the first 15 seconds, you pull your chest seal from your IFAK. 2 seals, matched pair. You open the first. You take a piece of gauze and you dry the skin around the wound. You don't scrub, you pat. You are removing the film of blood and sweat that would otherwise prevent adhesion. In the next 15 to 30 seconds, you peel the backing off the first seal. You center the valve over the wound and you press the seal down firmly, working from the center outward to push out air bubbles. You hold it in place with the flat of your hand for a full 10 seconds to let the adhesive grip. The sucking sound stops. The patient's breathing becomes easier. In the next 30 to 60 seconds, you roll the patient carefully onto their side to look for an exit wound. You find one. It's going to be low on the back on the same side, about the size of a thumbnail. That is your second seal. Dry the area, peel, apply, hold, roll the patient back. 1 minute plus. You reassess. Is the patient's breathing still easier? Are they becoming more short of breath, anxious, or confused? Now, those are signs of a developing tension pneumothorax. If the seal you applied is a vented seal and it is functioning correctly, the valve is releasing trapped air. If it is an unvented seal, you are now monitoring actively. And if you see tension signs, you burp the seal, right? And we do this by lifting one corner to release the pressure and then reseal. Hopefully, when EMS arrives in the next few minutes, you will perform your handoff. You tell them exactly what you did. 1 vented seal on entry, 1 on exit. How many times did you apply it? Did you have to burp it, etc., right? We don't want to improvise the facts here. They need to know exactly what you did. Penetrating chest wound, 2 seals, 2 wounds, dry skin before adhesion, monitor for tension pneumothorax. That is the device applied correctly in the most simplest of terms. All right, so what are the 3 takeaways from this episode? 1, a chest seal solves open pneumothorax, which is the pathway. It does not by itself solve tension pneumothorax, which is the pressure. The design choice between vented and unvented is entirely about managing that risk. 2, dry the skin before application. This is the single most common civilian failure with this device. A seal applied to wet skin does not hold, and a seal that does not hold is doing nothing. 3. Every penetrating wound is 2 wounds until you prove otherwise. Seal the entry, roll the patient, find the exit, seal it too. That is why CoTCCC recommended packs come paired. Now, I carry chest seals in my own IFAK and in all my trauma bags, and we sell them in many of our pre-built first aid kits or IFAK kits. Now, if you don't have chest seals in your kit and you want to do that, you may want to fix that before you listen to the next episode. They're very simple. They're very cheap, $15, right? They're about 3 inches square. They'll fit almost anywhere. And it's the difference between a patient who walks out of the ER and one who does not. If you don't know where to get them, you'll have a link in the show notes. Now, next episode, we pull back to the kit itself. Specifically, we'll start with your cart kit. And I'm going to make the case that most civilian cart kits are optimized for the wrong injury pattern, because the injury pattern in a motor vehicle collision is not what you think it is. I'm Dr. Marco Torres. This has been Talking TACMED. Stay ready, and I'll catch you next time.